Good afternoon, students. So, in the last class, I spoke about diabetes mellitus, right? Regarding diabetes mellitus with respect to the type 1 diabetes mellitus, which are all the clinical manifestations or the clinical biochemical changes which was observed in case of type 1 diabetes, that is hypertriacylglycerolemia as well as hyperglycemia and ketoacidosis conditions. So now let us see today what will be the treatment for this type 1 diabetes. So the individuals who are facing this problem, that is who are suffering from type 1 diabetes, first they must rely on this exogenous insulin, which is going to be delivered subcutaneously either by periodic injection. So you are giving the injection periodically, or even you can give continuous pump, which is going to be assisted uh, with particular treatment for the treatment of this particular type 1 infusion of this particular injection in order to control the hyperglycemic condition. So the person should not reach to hyperglycemic condition, that is nothing but the blood glucose level should be under control at the normal level. It should not reach more than 240 mg per deciliter, right? So, as well as we have observed ketoacidosis also. In order to control both hyperglycemic condition and ketoacidosis, so uh, they have made two kinds of treatment. That is two therapeutic regimes which are going to be currently in use. That is, one is the standard one and another one is the intensive insulin treatment. So, what is this standard regime versus this intensive treatment? So standard treatment especially refers to that it mainly consists of one or two daily injections of this recombinant human insulin. Means blood glucose level which is going to be obtained mainly that is going to be ranging from 225 to 275 mg per deciliter range with a glycosylated hemoglobin, that is HbA1c level, with a glycosylated hemoglobin, that is HbA1c level, which will be of 88 to 9% of the total hemoglobin, right? It is going to be of 8 to 9% of the total hemoglobin. So that is going to be in a that is the mean blood glucose level, that is a person which is having 225 to 275 mg per deciliter range, he will be having, or he or she will be having glycosylated hemoglobin, that is HbA1c level 8 to 9% of the total hemoglobin. So particularly, the rate of this formation of HbA1c is proportional to the average blood glucose concentration over the previous 3 months. That is, they are going to calculate this mean blood glucose level by going through 3 months blood glucose concentration, how the person or the patient has maintained. That gives you the mean blood glucose level, that is nothing but HbA1c, which is of 8 to 9% of the total. If the patient is having 225 to 275 mg per deciliter range. So this particular HbA1c, which is going to provide a measure of how the well treatment which has been done to the patient in order to normalize the blood glucose level concentration in the diabetic patient over the time. But in contrast to this particular regime, standard therapy, intensive treatment, which also seeks to be more closely normalized, we can do it uh, more closely, which is relevant to this regime, that is which will bring the blood glucose level to the normal level through more frequent monitoring. So you have to observe the patient with a that is, you have to keep on monitoring the patient, and subsequent injections of the insulin, which is going to be three or more times a day. You have to give to the particular person, or inject that person 3 or more times a day. So this mean blood glucose level of 150 mg per deciliter can be achieved with the HbA1c approximately 7% of the total hemoglobin. It should reach. Out of that 7% of the total hemoglobin, it should be reached. That is, if the mean blood glucose level at 150 mg per deciliter can be achieved with the HbA1c, then definitely the HbA1c level approximately ranges from 7% of the total hemoglobin. So yeah, one more note is that normal mean blood glucose is approximately 100 mg per deciliter and HbA1c is 6% or even less. So if the patient is having 100% sorry, 100 mg per deciliter, or even 100 to 120 mg. So you will be having the HbA1c of the total hemoglobin will be approximately 6%, or even less than that, that may be 5.7% also. So that is normal condition. So you can normalize the blood glucose value, that is called as euglycemia, which it is not achieved even in the intensively treated patients. So you have to maintain that particular normal blood glucose by giving the injection of insulin, monitoring the patient in order to avoid this. It should not be achieved with respect to that particular patient. Euglycemia should not be achieved even if you are treating that particular patient by intensively, that is intensive treatment, that is by giving the insulin injection continuously, right? That is 3 times a day. So the patient with this on this intensive therapy shows this 50% of the more reduction in the long term microvascular complications of this diabetes, that is nothing but retinopathy, nephropathy and neuropathy, which is going to be compared with the patients who is receiving the standard care. This confirms that the complication of diabetes are related mainly to the elevated level of the plasma blood glucose level, that is plasma glucose level. So in case of hypoglycemic condition, in case of type 1 diabetes, so one of the therapeutic goals can also be achieved. That is, we have to maintain the patient with a normal blood glucose, and we have to treat the patient to avoid the hyperglycemic condition, and at the same time we have to take care of that without precipitating hypoglycemic condition. So what is going to happen? So one of the therapeutic goal in case of this diabetes is to decrease the blood glucose level, which is an effort in order to minimize the that's what development of long term complications of the disease, of the chronic complications of diabetes. However, this appropriate dosage of the insulin, which is very difficult to achieve, but hypoglycemia, which is mainly caused by the excess insulin, is the most common complication of this with respect to this insulin therapy, occurring in over 90% of the patient. So usually it is going to occur in over the 90% of the patient, these complications. The frequency of this hypoglycemia, which is going to be coma, seizures, and particularly high with the intensive treatment regimes, which is mainly designed in order to achieve the tight control of the blood glucose level. So in order to avoid the hyperglycemic condition, we have this particular treatment is being designed or achieved in order to maintain the blood glucose level to the normal condition. So in case of the normal individuals, this hypoglycemia, which is going to trigger a compensatory secretion of the counter-regulatory hormones. Those counter-regulatory hormones are glucagon and epinephrine, which mainly promotes hepatic production of the glucose. However, the patient with this type 1 diabetes also develops a deficiency of glucagon secretion. So you might be knowing what is the level hormone function of glucagon. When the glucagon is going to act in our body, when it is going to release, when the blood glucose level is going to be, that is in the during fasting condition, right? During fasting condition, when the blood glucose level is low, so your glucagon hormone is going to activate the process of gluconeogenesis in order to synthesize the glucose, right? So this particular thing is going to happen. So what is going to happen now? If the hepatic production of the glucose, which is going to be promoted by this particularly counter-regulatory hormones. So when the patient with the type 1 diabetes also develops a deficiency of glucagon secretion, this defect, which is going to occur early in the disease, but it is almost universally present 4 years after diagnosis. So these patients, therefore they have to rely on this epinephrine secretion to prevent the severe hypoglycemia condition. So they have to rely on the epinephrine secretion in order to prevent the severe hypoglycemic condition. So what are the contradiction for this tight control of this hyperglycemic condition? So children which are not put on a program of this particular tight control of the blood glucose before age 1 year, because of the risk of this particular glycemic condition, which may develop for them, and shows the adverse effect on the brain development, especially elderly people, which is do not go on tight control, because hypoglycemia, which can lead to them for their may result in strokes and even heart attack for those kind of patient, that is elderly people in this population. So we have a major goal of this tight control in order to prevent complications. At the same time, we have to maintain this normalized level of glucose in the blood. So many years later, we can have it in those patients. They can make a tight control of this glucose level in the blood. So, but is worthwhile for the otherwise healthy people who can expect to live at least 10 more years. Adults with a diabetes, especially one more note for most non-pregnant adults with a diabetes, the individual treatment strategies and goals are based on the duration of diabetes, age, the life expectancy, and the known comorbid conditions. So if you come for the type 2 diabetes, so this is the most common form of the disease which is going to afflict over 90% of the diabetic population in the United States especially. So this type 2 diabetes which is going to develop gradually without obvious symptoms, especially the disease is often detected mainly by the routine screening tests. Many individuals with the type 2 diabetes which have the symptoms of polyuria especially and polydipsia of several weeks duration. So this polyphagia may be present but it is less common. But patients with this type 2 diabetes which is having a combination of insulin resistance and as well as dysfunctional beta cells, both we can observe, that is insulin resistance and dysfunctional beta cells, but do not require insulin to sustain their life. Although this insulin eventually will be required to control hyperglycemic condition and keep HbA1c below 7% in over 90% of the patients. The metabolic alterations observed in type 2 diabetes are milder than those described for the type 1, especially in a part because insulin secretion in type 2 diabetes, although inadequate, does restrain ketogenesis back and blunts the development of diabetic ketoacidosis. So, yeah, you can recall that insulin which is going to suppress the release of glucagon. So, it is going to suppress the release of glucagon. That means it will avoid the synthesis of glucose through gluconeogenesis process. So diagnosis is mainly based on the presence of the hyperglycemic condition, as the pathogenesis which is not involved, that is does not involve viruses or even autoimmune antibodies, which is not completely understood here in case of this diagnosis purpose with respect to this presence of hyperglycemia condition. One more note is here, an acute complication of this type 2 diabetes in case of elderly people is a hyperosmolar hyperglycemic state characterized mainly by the severe hyperglycemia condition and dehydration and even altered mental status. So you can observe all these things. Severe hyperglycemia condition, dehydration and altered mental status can be observed. So this type 2 diabetes is mainly characterized by the hyperglycemia, insulin resistance, impaired insulin secretion and ultimately beta cell failure. So the essential need for the insulin therapy has eliminated, especially the designation of type 2 diabetes as non-insulin dependent diabetes. That's why they are going to call it as non-insulin dependent diabetes for this type 2 diabetes. So what are all the things which we can focus on this particular type 2 diabetes? The condition or the manifestations or the biochemical changes what we can observe, that is insulin resistance. So in this case, insulin resistance is the main decreased ability of the target tissues such as liver and adipose and even muscles to respond properly to the normal level of the glucose for the elevated circulating concentrations of the insulin, especially. For example, this insulin resistance is mainly characterized by increased hepatic glucose production. So, and as well as decreased glucose uptake by the muscles and adipose tissues, and even you can observe increased adipose lipolysis can happen with the production of free fatty acids. More amount of free fatty acids will be produced because of the increased lipolysis in case of the adipose tissue. So what is going to happen with respect to this insulin resistance and obesity? Although obesity is the most common cause of this insulin resistance as well, in type 2 diabetes, most people with obesity and insulin resistance do not become diabetic. In the absence of a defect, especially in the beta cell function. So in the beta cell function, in the absence of a defect in beta cell function, and even in case of non-diabetic, obese individuals can compensate for the insulin resistance with the elevated levels of the insulin. For example, if you come across, insulin secretion is 2 to 3 times higher in obese subjects than in the lean individual. Understanding? So insulin secretion is going to be 2 to 3 times higher in obese subjects than in case of the lean individuals. So this higher insulin concentration, which is going to compensate for the diminished effect of the hormone. As a result of this particular insulin resistance, which is going to end up in blood glucose level, which is similar to those of the observed in case of the lean individuals. So we can see with respect to this comparison, we can compensate with respect to the diminished effect of this hormone, that is insulin, in case of insulin resistance, who is going to produce blood glucose level similar to those of the person who is going to be observed in the lean individuals. So you can see here what is this obesity, which leads to the changes in that particular secretion, right? So you can make out what are all the things which is going to happen, that is insulin resistance. So where you can make out the synthesis of more amount of fatty acids production, right? Free fatty acids will be released because of lipolysis condition, and you can also make out this hepatic liver gluconeogenesis process, which can happen for the production of more amount of glucose, which is uptaken by the adipose cells and the adipose tissues and even the muscles, and the blood glucose level will be how the condition which is going to happen in case of the similar to those of the lean individuals, what we can observe in case of obesity and insulin resistance person. So both the things which is going to happen. So what will be the situation in case of insulin resistance and type 2 diabetes, how it is compensatory, that is compared. So insulin resistance alone will not lead to the type 2 diabetes, of course. Rather, type 2 diabetes, which also develops in insulin resistant individuals who also showed impaired beta cell function. So this insulin resistance and subsequent risk of the development of type 2 diabetes is commonly observed in case of the individuals who are who are obese person and physically inactive or elderly, and in the 3 to 5% of the pregnant women we can observe this, the development of this gestational diabetes. So these patients are unable to sufficiently compensate for the insulin resistance with the increased insulin release, further which shows the time course of the development of hyperglycemia. So further progresses this particular disease, so we can observe the development of hyperglycemia condition and the loss of beta cell function. Understanding? So you can make out here blood insulin and glucose level in normal weight and obese subjects, what is going to happen. So insulin level in the blood, which we can make out in case of this, what will be the curve you can observe here, right? In case of obese and in case of normal, blue mark graph is indicating, the line is indicating the normal, and red indicating the obese. In case of obese individuals, so you can see this particular blood insulin, right, which is having basal levels of this particular, you can observe this particular line, that is red color in case of obese individuals, right? This will be the condition which we can observe in case of insulin level in the blood, whereas glucose level in the blood you can make out here. So here the both red and blue line, you can see obese and normal. What is happening in case of this particular person, so you can see within the particular line, so how the mark you can make out both concentration, right? In case of the normal weight with respect to the individuals with which is compared with the lean individual, right? Obese individual with respect to the lean individuals, you can make out the glucose level in the blood. So this is how you can see blood insulin and the glucose levels in the normal weight, and even in case of the obese individuals we can make a comparison with respect to the both insulin and the blood glucose level. So one effect of the insulin resistance is mainly increased because of the lipolysis and the production of more amount of free fatty acids which are going to be released into the blood. So this free fatty acid availability, which also decreases the use of glucose, contributing to the hyperglycemic condition, and also we can make out the increased deposition of triacyl glycerols in the liver, right? That's why we have end up in hypertriacylglycerolemia. Understanding? So triacyl glycerols in the liver, so that is nothing but hepatic steatosis we can also call. This free fatty acids which also have an pro-inflammatory effect in the long term complications. So free fatty acids which is going to suppress further glucose induced insulin release. So one more note is that adiponectin, which is going to increase fatty acid, that is beta oxidation. Through beta oxidation process, you are end up in increased free fatty acids. As consequently, you can also see decreased in this adipocyte, that is protein which is contributing to the free fatty acids availability. So both the things which we can observe in the long term, if the free fatty acids, which is going to suppress the glucose induced insulin release. So you can make out in this particular progression of the blood glucose and insulin levels in the patients with the type 2 diabetes. You can see here. It is very clear. You can understand very easily with respect to this graph, right? Now coming for the beta's dysfunction of the beta cells. So in case of the type 2 diabetes, as I said you earlier, the pancreas, which is going to initially retain the beta cell capacity, resulting in the normal insulin level, which is going to vary from above normal to below normal. However, with time, as the progression of this particular disease type 2, with the time, with respect to that time, you can observe the particular insulin level which is going to vary from the above normal to the below normal. The beta cell, which is going to become increasingly dysfunctional and fails to secrete enough insulin in order to correct the prevailing hyperglycemia condition. For example, insulin levels are higher in typical obese individuals, type 2 diabetes patients, but not as high as a similarly obese individuals who are non-diabetic. Understanding? With respect to the if you are comparing with a non-diabetic patient, obese individual, with a diabetic and obese individual, so you can see this particular process, what is going to happen. Insulin levels will be higher in typically obese with a type 2 diabetes, but not as high as in similarly obese individual who are non-diabetic. So you can see that natural progression of the disease results in a declining ability to control hyperglycemia condition with endogenous secretion of the insulin. So further ending up in deterioration of this beta cell function, which can further result in accelerating the by the toxic effects of this sustained hyperglycemia condition, and as well as elevated free fatty acids and a pro-inflammatory environment. So these are all the factors which plays a very important role in making this particular beta cell dysfunction, causing dysfunction in the beta cells or deterioration of the beta cell function. So let us stop now. Next I will explain you about progression of this type 2 diabetes. Thank you.